The Surgeon General's report last November was a big deal thing because the Surgeon General never got out a report before about addiction, about alcoholism and drug addiction. Back in 1967, the Surgeon General did a report about smoking. Now, I've never followed the rules and regulations that he mentioned about smoking, but a hell of a lot of the country has, because 41% of the country used to smoke cigarettes. There's a great picture of Jane after our first child was born in 1960 in the hospital with the oxygen tent smoking a cigarette. That changed the culture. The culture about alcoholism and drug addiction is more difficult to change, but certainly the Surgeon General's report may be a step in the right direction. As Jane and I watch 60 Minutes these days, every single ad is for a pill. Something to make us feel better. We get excited, and then we listen to the end of the commercial. This may cause suicide, sudden stoppage of the heart, and your hair will fall out. But in a country where most of the ads that go into television now are pushing drugs, either drugs from your doctor or drugs from the drugstore without a prescription, you got to wonder why it is that this whole drug crisis is part of our culture. As we reach out and tell people about Oxford House and how you can improve the culture, that's going to be a plus. But as the Surgeon General report set a landmark for changing this culture, we're very fortunate today to have Dr. Clark with us to talk about what this change means and how we can respond to it. Dr. Clark.
Thank you, Paul. And I want to thank all of you for being here and for having me here. I want to acknowledge the presence of Stu Gidlow, a longtime colleague at ASAM, the American Society of Addiction Medicine. We have a long-term commitment to addressing the issue, and as I've talked to many of you in the past, we'll continue to discuss the issues associated with facing addiction. Now, as was pointed out, I'm going to talk about the Surgeon General's report. The Surgeon General report came out in November of last year, and as was pointed out, it is the first time that the High Office of the Surgeon General has addressed the issue of addiction. And it was not that addiction surfaced for the first time. It's just that, as many in our society have treated the issue of substance use disorders, of addictions, of people with substance use disorders, or as Paul often says, dealing with druggies and addicts, even though that's not the appropriate language. But key issues, we struggle with this. Would like for you to understand, I'm going to appreciate your feedback on this presentation for this report. We'd like to evaluate this report, and because what we want to do is to promote the report to everyone in the community. It wasn't written for scientists. It wasn't written for clinicians. It was written for everyone. And we want this report to be used by anyone interested in communicating aspects and issues associated with addiction, with substance use disorders. It is important that you have a tool at your disposal to be able to do that. Now, there are 5 overarching messages associated with this report. The report was put together with the senior editors, Tom McClellan, other editors involved, Nora Volkoff, whose name you heard this morning, George Koob from the NIAAA, Nora Volkoff is with NIDA, people like Rico Catalano for prevention, Keith Humphreys for recovery, Connie Wisner for health systems, and I focused on the treatment section. We want these overarching messages so that the public understands that both substance misuse and substance use disorders harm the health and the well-being of individuals in the community. That we need to address those issues and that we can address those issues with effective strategies, Oxford House being one of those effective strategies. Highly effective community-based prevention programs and policies do exist and should be widely implemented. We want that message to get across. We want full integration of a continuum of services for substance use disorders with the rest of healthcare so that we can improve the quality, effectiveness, and the safety of all healthcare. We heard from North Carolina, which pointed out that housing and recovery reduce healthcare costs, and that Oxford House has played a critical role in helping to reduce healthcare costs. So it's not just about some abstraction. This is about the wealth and health of the larger community. We need to have coordination and implementation associated with parity laws. You're entitled to get appropriate care depending upon your jurisdiction, and that there are laws that say that your insurance companies can't discriminate in terms of providing services, so that these can increase access to services. Some people do need treatment and a professional environment. Hopefully the laws in the jurisdictions in which you find yourself will allow that to happen. We know that there's a large body of research that talks about the biological, psychological, and social underpinnings of substance misuse and related disorders. And they describe effective prevention, treatment, and recovery support services. We also need future research. We've researched all sorts of things, but one of the things we haven't done is adequately address the research associated with substance use disorders. The first Surgeon General report came out in 2016. That was not the first year that we had an addiction problem. So the report is constructed. It has 7 basic chapters. Those chapters, I'll go over them very quickly and then march through them because I don't want to take up all of your time. Chapter 1 is an introduction and overview. Chapter 2 deals with the neurobiology, essentially the science of addiction. And I'm going to show you a couple of slides about that. Chapter 3 on prevention programs, because as you work with the communities in which you live, remember, Oxford houses are part of communities. As you work with the communities in which you live, it is important to have messaging at your disposal. And this report is available. You can download it off the internet. Each chapter has a separate PDF, and so that you can share this information with the communities in which you live, as well as with yourselves. I hear a young child in the audience. We need to keep in mind, this is indeed not just about you, it's also about the children. There's a chapter on early intervention, treatment, and management of substance use disorders. Chapter 5 is on recovery, the many pathways to wellness. Chapter 6, healthcare systems and substance use disorder. And Chapter 7, a vision of the future. So we start off saying there's reason for hope and optimism. And the fact that you're here gives me reasons for hope and optimism. And I've appreciated Oxford House. And as was pointed out by Flo Stein earlier, start off with a small group of people. You continue to grow every year that I'm here. I see more and more people demonstrating that not only is recovery is possible, but the kind of enthusiasm that you bring, the insightful questions that you ask, that demonstrates hope and optimism. So prevention and treatment for substance use and related harms, and not incarceration. Incarceration does not solve the problem of substance use disorders or substance use. We need a society that recognizes the public health implications of substance use. We need research providing understanding and evidence of the effectiveness of prevention policies, new medications and behavioral therapies, and the chronic care model where it's applicable. and policies that offer new opportunities, expanded access to prevention, treatment, and recovery, and integration into mainstream health. So when you show up at the clinic, you show up at the physician or the nurse practitioner or physician assistant, you show up, you get quality care that's respectful of your autonomy and as your personhood, and not someone who's discriminated against. Chapter 2 deals with neurobiology, and I only have a couple of slides because this isn't about neurobiology, but you should keep in mind that the researchers have come to grips with the fact that there are these basic models, there's neurobiological issues associated with the use of drugs. It explains why some people transition from using or misusing alcohol or drugs to substance use disorders, because we all know that not everybody who experiments with or uses alcohol or drugs develops a substance use disorder. Some people say, well, I'm envious of those people. How do I become like those people? But those people who develop substance use disorders need to understand that. And it explains how substances produce changes in the brain. It is a brain disorder. Go from the model that the NIH is promoting, recognizes that certain parts of the brain are affected, like the midbrain and what they call the prefrontal cortex, the front part of your brain, the part that makes decisions, the part that keeps you from doing impulsive things or not. So you go from binge intoxication to withdrawal and negative affect, to preoccupation and anticipation. So these are the three stages that are involved that the NIH recognizes. But the most important thing is that it's a brain disease. The next slide is a bunch of cells. These are neurons. But the important part of this slide is it talks about the relationship between the various substances and the neurotransmitters, particularly dopamine, and those various cells. Because some people say, well, if I have an opioid problem, I can drink. Or if I have an alcohol problem, I can smoke. Or so the person who says that's right, who says, so I'm not going to die of an alcohol-related liver disease, I'm going to die of lung cancer. That's right. It'll be your problem when you develop the problem. But the key issue is to understand that these things are often interrelated and that there's a science there and that people quickly realize, oh, I need to be careful if I'm looking for something that's going to alter my mind and mood, and I've already developed a problem with one substance, I may have another problem with another substance. They're using science, MRIs, magnetic resonant imaging, and positron emission tomography to show that some of these changes can be identified and that they can be sustained, and they interfere with your potential for recovery. So what we learned in Chapter 2, which, again, you can download, that addiction becomes more severe with continued substance use. Well, duh. As they say, can I just do a little bit? Just a little bit. The Lay's potato chip, for those who can remember it. Can you just eat one? That there are dramatic and persistent changes in brain regions that control feelings of pleasure, stress, and feelings of unease and anxiety and irritability, which often accompany withdrawal, and your executive function, how you organize your thoughts and decision-making. Substance use does hijack these important areas of the brain. It does not mean that you cannot address these issues. It does mean that you have these overwhelming urges and overwhelming desires. So the conclusion from Chapter 2 is that addiction is a chronic brain disease. With addiction, there you have dramatic changes in brain function. The brain changes persist long after substance use stops, and we're trying to figure out, well, how long? It depends on the individual, it depends on the substance, but the key issue is that with programs like Oxford House, you buy some time. 12-step programs, long ago when I was dealing with 12-step programs, they recognize Don't do anything for the first 90 days. Why? Your brain is still affected. Hello? And you have a hard time making decisions. It's sort of this paradox. The thing that you're going to use to make a decision is adversely affected by the things that you use. The substance, the alcohol, the cocaine, the heroin, the marijuana. So the things that you're going to use to make a decision is adversely affected by the things that you use. You're going to use your brain to make the decision. I'm not going to spend my last dime on booze or drugs. I'm going to pay my rent. Well, somehow the rent's going to get paid, but I got to buy this. But in any event, the other issue is that adolescence is a critical period. It's an at-risk period. We've got children in the audience, and the most important thing we want to do is that all addictive substances have especially harmful effects on the adolescent brain, because the adolescent brain is still undergoing change, maturity, development. So we get to prevention then. We know that misuse of alcohol and drugs is associated with health and social problems. We know that prevention stops the progression from substance use to problematic use to substance use disorders. We know that prevention makes economic sense. The research shows that prevention programs can save between $1.61 and $64 in societal costs for every dollar invested, depending on the project. We know that prevention works. But we're not willing to invest in prevention. It's an odd thing. So from Oxford House's point of view, that as you recover, it offers you an opportunity, particularly when you're interacting with your community, to be able to point out there's this wealth of information about prevention. And who is in the best position to talk about prevention? Those individuals who have experienced the effects of substance use. There are risk and protective factors that predict substance use problems, and there are targets that we want to address. Risk and protective factors that are consistent across diverse populations. That's what I love about Oxford House. I have seen you have the most diverse population and an audience in a long time. You cover the spectrum. And I'm no longer with the federal government, but I wish Secretary Price were here. Because they need to see that when we talk about programs like Oxford House, you reach the community. You're the bulwark of our community. And you represent the full spectrum of our community. Different community and neighborhoods have different levels of risk and protective factors. But the key issue is you come from all of those communities. And so those people who run around and say, well, not my community, should come to an Oxford House World Convention meeting. And they will get to say, oops, my bad. Over 60 prevention programs and policies have been shown to prevent substance use problems in rigorous research. Communities are an effective organizing force for bringing evidence-based policies and programs to scale. This notion of communities, and I love what Paul was saying. This is a community. This is a family. You bring things to scale. You influence each other. I was in the North Carolina session, essentially driven by North Carolina. But the most important thing is what surfaced was, what is the community doing? What is the house doing? What is the network doing? People say, well, my house isn't having a party. My people don't associate with each other, with the other houses. The response was, why not? Good question. So we need to make sure that communities are an organizing force. And one of the things that we know is that if we don't have the community, we can't rely on what I call instrumental solutions, like state policies for reducing inappropriate prescribing. They make these laws and they assume that the problem will go away. And they don't. Chapter 4, Early Intervention, Treatment, and Management of Substance Use Disorders. I want to spend just a little time on this before I get to what I think is the most germane chapter. So this chapter looks at the scientific evidence supporting the effectiveness of treatment interventions, therapies, services, medications available to treat substance use disorders. And there are, again, you can download this. It is in plain English, and we didn't use a lot of dialogue. We know that there are effective strategies and services ranging from self-change to specialty treatment. We want to promote screening in the healthcare system. When you go to your doctor or your nurse practitioner or your physician assistant, you should be able to discuss your substance use without the fear of discrimination. Early intervention, treatment, and the management of treatment and recovery support services. We know that substance use disorder treatment, like treatment for other illnesses like hypertension, like diabetes, like asthma, it's designed to stop or reduce the major symptoms. It's designed to improve the health and social function, and it's designed to help you recognize and manage the risk of relapse. So not everybody's ready for prime time. We know that a number of people who start Oxford houses relapse. They need to be able to engage the system of care, and they need to understand that that system has their health and interest, and that you also need to know you're not banishing people. You're having them re-engage with the healthcare delivery system, and hopefully so that they can represent. So screening, substance misuse screening. So everybody in the healthcare system, primary care, urgent care, psychiatric care, school health clinics, emergency care, should be asking about alcohol use, should be asking about cocaine use, heroin use, prescription drug use, etc. There should be brief interventions where the practitioner talks about this issue, and they should be provided to adolescents and adults who are at risk. And then there should be ongoing monitoring, because it's important to build a trusting relationship, not only with each other in Oxford houses, but with your healthcare delivery system, to promote a reduction in substance use, or in case of Oxford House, abstinence from substance use. You want to be involved in a system that has an individualized treatment plan. We recognize the importance of individualized treatment plans. Without an individualized treatment plan, you're just another cookie in the cutter. Goals that should be person-centered and strength-based, the kinds of things that Oxford House nudges you toward. Strength-based. What's good for you? What do you recognize that's good in you? We should target our efforts to keep you engaged either in Oxford House specifically or in care. Care should consider both physical and mental health issues, and it should be culturally competent. As I mentioned, you're diverse. You should consider age, gender, identity, race and ethnicity, language, health literacy, religion, sexual orientation, culture, physical health problems, and or co-occurring conditions. We know there are some medications. There are 3 approved medications to treat alcohol use disorders. There are 3 other medications for opioid use disorders. But there are no medications for marijuana, cocaine, methamphetamine, or other substance use disorders. So those people who think that there's another pill, as Paul suggested, because the TV tells you that if you don't like the psoriatic patches on your skin, we've got a drug that will help you with that. But as he also pointed out, it may create other problems that are much worse than having a, quote, unsightly patch on your skin. But they're promoting them. There are no approved medications for marijuana, cocaine, methamphetamine, or other substance use disorders, so we can't rely on the magic pill. Well, we need to recognize the importance that there are behavioral therapies for substance use disorders that to deal with some of the issues associated with substance use. Individual therapy, group therapy, family sessions, these things have been known to work. These structured therapies help people recognize the impact of their behaviors, such as dealing with stress or interacting in interpersonal relationships, on their substance use and the ability to function in a healthy, safe, and productive manner. Life can be stressful. Interpersonal relationships can be stressful. Supervisors on the job can be stressful. And you need to be able to articulate that, because once you develop a substance use disorder or problem, you can't then say, well, maybe I can just do a little one just to get through a little day. It doesn't work that way. That's not how it's done. These therapies teach and motivate people in how to change their behaviors in a way to control their substance use disorders. So the treatment chapter is a little more lengthy than that, But the key issue is that substance use and misuse can be reliably and easily identified through screening. Substance use disorders can be effectively treated, and medications can be effective, but they're not medications for everything, and treatment is cost effective. Chapter 5 deals with recovery. There are many pathways to wellness. Recovery from substance use disorder has several definitions. The different organizations have different views of what recovery is. Abstinence, often necessary, is not always sufficient to define recovery. We need to recognize that remission from substance use disorder, which is a reduction of key symptoms, that's more common than people realize. Supported scientific evidence indicates that approximately 50% of adults who once met diagnostic criteria for substance use disorder, that's about 25 million people, are currently in stable remission 1 year or longer. Remission from substance use can take about 5 years. Some people have to have several bites at the apple before it takes. But it takes, for some people, multiple episodes of treatment, recovery support services, and mutual aid. People who suffer from substance use disorder, these are the values and beliefs, have essential worth and dignity, whether they're recovering or not. The respect for the dignity of the person is important. Shame and discrimination prevents many individuals from seeking help, and it has to be combated. This is what's in the report. Recovery can be achieved through diverse pathways and should be celebrated. Access to high-quality treatment is a human right, although recovery is more than treatment. People in recovery and their families have valuable experiences and encouragement to others, and people can learn from that. You are all messengers, whether you realize it or not, whether you want to be or not. There's somebody waiting to hear your message of hope, strength, experience, and recovery. The Surgeon General's report noted that after looking at 9,000 people, that 86% of the people saw abstinence as an important part of their recovery. So Oxford House's principal theme of abstinence is supported by the research. Another principle is personal growth, being honest with yourself, handling negative feelings without alcohol or drugs, and being able to enjoy life without alcohol and drugs. And since we were in the session next to the fun house, it was clear that somebody was enjoying themselves. But the other theme is service to others. It's an important issue, service to others. So the Surgeon General report recognized that there are a number of recovery support services, mutual aid groups like 12-step programs, recovery coaching, peer recovery coaching, recovery housing, recovery management, recovery community centers, and recovery-based education. So we talk about, in the report, mutual aid groups like 12-step programs. These are the best known. These are basically peers helping peers. These are members are sharing their problems of the status that they value, the experiential knowledge. People want to know, can it be done? You're in a position to tell them that it can be done. You can learn from each other's experiences. That's a central element. That's what the house does. Groups are voluntary associations, and the 12-step groups, they charge no fees and they're self-led. The report goes on to talk about recovery housing. So it notes that a substance-free environment and mutual support can benefit an individual during and or after outpatient treatment. Okay. Recovery housing residents informally share resources with each other, give advice about how to find employment, manage legal problems, interact with social services, access health care, and have fun. The blueprint is not in the report, but Oxford House is in the report. Oxford House is in the report. So, I mean, clearly you've got over 2,000 houses. You're in over 43 states, the District of Columbia, Canada, and Australia. And the report points out that you're the leading example of recovery supportive housing. Now, there are a bunch of recovery housing in the environment, but Oxford House is the leading example. It's in the Surgeon General's report. It notes that Oxford House are peer-run, self-sustaining, substance-free residents that hold 6 to 10 recovering individuals per house. It requires all members to maintain abstinence. They encourage but do not require participation in 12-step mutual groups. All of this is in the report. Now, of course, you already know this. But you're in the Surgeon General report. So you got some external validation, not that you needed it, but it's always nice. You know, everybody likes a little props. Everybody likes to be acknowledged from time to time. I mean, you know you're good, but it's nice to have someone say, "You good?" At least I think so. The Surgeon General report noted that a randomized controlled trial found that people with severe substance use disorders who were randomly assigned to live in an Oxford House after substance use disorder treatment were 2 times more likely to be abstinent and had higher monthly incomes and lower incarceration rates at a follow-up 2 years later than similar individuals who received standard continuing care. Like I said, you're in the report. You've got evidence. So what you are doing is supported by the Surgeon General. What you are doing is supported by the research. So that should be nice to hear. And for me, since I've been coming to these meetings for many years, it means I'm not wasting my time. Oxford House saves money. The net cost benefit to the healthcare and criminal justice system from Oxford House assignment compared to standard care, basically the estimated cost benefit of Oxford House was $29,000 per person over a 2-year period follow-up. Okay? So the bottom line is, back to the blueprint, recovery housing can be cost effective, and that's based on what we know from Oxford Houses. Can be effective in supporting recovery. So this is a key issue. This chapter, Chapter 5, which you can download as a PDF file, you can use when people in your neighborhoods are saying, "We don't want another Oxford House in our neighborhood. We don't want," as Paul says, "druggies and alkies in our neighborhood." The fact of the matter is, you contribute to the health and well-being of the community and to yourselves. And I would point to that. You talked to a judge this morning. The judge, here's the data. It's not my data. It's the Surgeon General's data, and he got it from the research. So, hey, I know we look good, but I didn't say it. It's an important theme, because it's not often that you get this sort of external validation. You don't have to just toot your own horn. You now have an orchestra. So we know there's well-supported scientific evidence that demonstrates the effectiveness of 12-step mutual aid groups focused on alcohol and 12-step facilitated interventions. We know that certain housing, like Oxford Houses, terribly helpful and useful. Evidence for the effectiveness of other supports is promising. And we know that this is a well-studied area that needs to be more studied. The conclusion is that we should celebrate and support recovery and let it stand, but let it stand on its own. We should make healthcare systems amenable to recovery concepts and people. So when you're working with these large MCOs, medical care organizations, they should recognize the utility of recovery housing. Science should invest in research on the effectiveness of various recovery supports, because we know that not all things fit all people. So while So many of you are the beneficiaries of Oxford Houses. There are some who don't benefit. We can expand research on innovative emerging recovery supports so that we can foster diverse communities. Chapter 6 of the report deals with healthcare systems and substance use disorders. As our healthcare delivery system transforms, they've got all of these systems that are evolving. We do want closer integration of substance use-related services to mainstream healthcare so that indeed we can address these issues earlier in a person's life. Substance use disorders are medical conditions, and their treatment has impacts on and impacts other mental and physical health conditions. We know that integration can help address health disparities, reduce healthcare costs for both patients and their family members. I want to acknowledge the importance of the family members, not just the children, but indeed, as I've often said in the past, and Yvette has heard me, families are often the last to let you go and the last to take you back. In part because, quite frankly, they've heard it all before. And by the time they let you go, you got to work your way back because they heard it all before. We know that there are special population issues, pregnant women and newborns. We've heard about narcotic abstinence syndrome earlier today, youth and young adults, underserved populations, including racial and ethnic minorities, the elderly, sexual minorities, and rural communities. Anybody over 65 in Oxford House as a resident? Well, that young man, because he's younger than I am, that young man represents a growing population segment. The baby boomers, I was born in 46, we baby boomers are aging, and we're not immune. So people who are elderly should be welcomed. Sexual minorities and rural communities. Individuals exposed to trauma, because trauma is a major issue with those with substance use disorder, both physical, emotional, and sexual abuse. Individuals in high-risk environments, including the homeless, the justice involved, and service members deployed in war zones, and then people with co-occurring disorders. So the conclusion of Chapter 6 is that integrating care for substance use disorders into mainstream health care can increase quality, effectiveness, efficiency of health care. Health IT, electronic health records, and computer programs, and apps, and wearables, that is increasingly being used to facilitate integrated care. We also need a larger, more diverse workforce, and hopefully some of you participated in that workforce with skills to prevent, identify, and treat substance use disorders. Substance use disorders are not well represented in the workforce in terms of knowledge. Today's workforce doesn't have the capacity to meet the existing need for integrated care, and the general health care workforce is undertrained. So you should be aware of that. The final chapter is Chapter 7, which is the vision for the future. It's a public health approach. Both substance misuse and substance use disorders harm the health and well-being of the individuals and communities. So we need to address that with effective strategies. Highly effective community-based prevention programs and policies exist, and they should be widely implemented. Full integration of the continuum of services for substance use with the rest of healthcare would improve the quality of care. Coordination and implementation should occur. Research should be pursued. So the next question, the final questions are, what can Oxford Houses do? You can expand evidence-based intervention by working with community leaders and community coalitions to implement prevention, treatment, and recovery programs and policies. Use the Surgeon General's report to document that position. You can use the Surgeon General report to inform your own members, your families, and the public and community leaders about the science behind your condition. It does not mean that you're brain damaged. It does mean that you've been exposed to a condition, substances that affect your brain and that you're recovering from. Mobilize different segments of the community. Engage with stakeholders such as other people in recovery, policymakers, law enforcement, healthcare, education, businesses, and the faith community to encourage change. You're in a position to do that. There are over 1,200 people here. You're a strong army. You need to encourage parents to talk to their children. Refer parents to the Surgeon General's report on addiction for background information. Encourage them to talk to their children about alcohol, drugs, and the risks they face. We need to continually assess the accomplishments, needs of people in the community, recovery community needs, and stakeholders, and adjust strategies. You can use the Surgeon General's report for that. And then you can use your imagination and understanding of hopes, experience, and strengths of people seeking to recover from the effects of alcohol and drugs to envision a new reality. You are envisioning a new reality, and you can use the Surgeon General report to promote that. There's a website where you can get collateral materials, the Surgeon General website, www.addiction.surgeongeneral.gov, and you can read that, you can download things, and that will give you additional material to address these issues. I hope you find this helpful. If you have any questions, please look at, give me a call, write me a note. I want you to be able to address these issues. It's important that you continue addressing the issue of recovery because it's a lifelong proposition. And I have a disclaimer. This is, I'm not an employee of the federal government, and I'm just talking about the report because it needs to be discussed. Thank you.